Sir, we are live now.
So, good morning, respected faculty and dear delegates. Today, again, a fine Sunday morning. We are here with the second last session of the rheumatology online sessions. Today's speaker will be Dr. Anu Gulati Maheshwari, ma'am. She is Professor of Pediatrics at Kalavati Saran Children's Hospital. We are being joined by Dr. G.S. Chaudhary, who will be chairing the session today, and Dr. Bennett Xylem. And I request our secretary, Dr. Shyam S. Meena, to please welcome all the faculty and the chairpersons.
Hello, very good morning to all. And thanks to our core organizing team and program this module, those who made and contribute in this program, especially Dr. Ajay and Dr. Anu Gulati and their team. Thank you, ma'am. You did the wonderful job. I think in the last 10 to 11 sessions, we really enjoyed. We get a lot of the feedback from our student as well as private practitioner, because in this online session, all are the expert are the very they made the very practical things and very real time case scenarios that is very useful for our practitioner as well as our residents. So thanks to our definitely those who contribute to build up this program, and most welcome to our today's chairperson, Dr. Ghanshyam Chaudhary sir. Sir, one welcome in the on this platform. And thanks to Dr. Anu, ma'am, accepting this today's session as a speaker for this program.
Thank you
Over to Dr. Ajay sir.
Thank you. As we know, we have a term called idiopathic conditions, where it is idiotic for the doctor and pathetic for the patient. So similarly, today's session is vasculitis syndrome, which normally present as a fever with rash. So I request Dr. Chaudhary sir to please say a few words.
Thank you, sir, for giving me opportunity. It's pleasure for me to with that a big platform of Delhi IAP. So today's topic is vasculitis syndrome overview and management. It is a common thing, so I think Dr. Anu Maheshwari will justify this, and we all will benefit with this. So over to you, sir.
Thank you, Dr. Chaudhary sir. Dr. Bennett sir, you want to say something, or we start with the session?
Okay, you can start, sir. Thank you very much for informing me also. It's a wonderful morning, and it's very useful. This program is I am watching only mainly because for my own learning.
Okay,
thank you for calling always. Thank you, sir.
I request Dr. Anu Maheshwari ma'am to please share her screen and start the presentation.
Thank you, Ajay sir. Thank you so much. I thank you, organizers, especially Dr. Shyam, Dr. Pankaj sir, Dr. Ajay sir, and all my colleagues who have really participated and helped make this this a success. 1 minute. Are my slides visible?
Yes.
Slides visible. Please make it full screen.
Hanji sir. Hanji.
That's great.
Okay.
Yep.
So topic for today, when I started interacting with Ajay sir in the morning, I said, sir, today's topic is going to be very difficult. It's difficult because, you know, these patients will not come to me saying, look, I'm vasculitis, treat me. Most of the patients will go to neurologists, gastroenterologists, general pediatricians, infectious disease specialists. You name the specialty and they would go there. Except coming to me, they would go everywhere else. So it's not only me or a rheumatologist who needs to be aware of these syndromes. The other pediatric specialties really need to make themselves aware of these vasculitic syndromes, because sometimes, you know, there's a saying that patient doesn't know what's happening, the doctor doesn't know what's happening, but the patient's illness is progressing. And what do? We sometimes are in a soup. I will be presenting 2 cases also along with my quick presentation, a real-time cases where we were really, it took us a lot of time, it took us a lot of energy, inputs, coordination, multidisciplinary. So having said that it's a difficult disease, I want to go through my slides. So what is vasculitis? Just a minute, please. Just a minute, sir. ये कुछ problem हो रहा है. ये my slides are visible, right?
Yes.
Oh, just a minute. Yeah. Yeah, what is systemic vasculitis? With systemic vasculitis are basically inflammation of vessels. So where are the blood vessels? Blood vessels are everywhere. Brain, eye, kidney, gut, skin, everywhere. So symptoms would also be everywhere. So systemic vasculitis is blood vessel inflammation, which may lead to tissue injury because of inflammation. Because the vessels are getting inflamed, they can get stenosed, they can get occluded, they can have aneurysm, which can burst, lead to bleeding, and obviously, whichever organ's vessel is being involved, that is the symptoms that's going to occur. Let's say, suppose it's primarily the skin. So you'll have some rash, some purpuras, some livido reticularis, some urticarial lesions. Urticarial lesions, how do we distinguish? You make a circle around that lesion. If the lesion is persisting beyond 24 hours, then it is vasculitis. Otherwise, it is a normal urticaria of childhood. So skin can be involved. Kidneys, you can have kidney involvement in the form of glomerulonephritis, hematuria, proteinuria, rapidly progressive renal failure. You can have severe abdominal pain, IBD-like picture. The patient can have mesenteric ischemia, intussusception, so many other symptoms. CNS, he can have a stroke, he can have seizures, he can present like tubercular meningitis. So multitude of symptoms because blood vessels are everywhere and we are talking about inflammation of blood vessels. My slides? Yeah. Okay, so vasculitic syndrome, just take home this message. There are of three types. I will be talking about mainly the primary vasculitis, which is caused by rheumatological or CTD-like illnesses. Secondary vasculitis like drugs, mycoplasma infections, rickettsial infections, toxins because of recreational drugs. I will not be talking about that. There is another category of vasculitis which is coming up where we have vasculitic features in a very young child. They present like vasculitis but do not respond to therapy. So that is a category of monogenic vasculitis, which I will be presenting one case because I want you to apprise you of these entities. So clinical symptoms can vary very widely. Systemic inflammation with vascular involvement. Systemic inflammation means what? The patient will be coming to you with fever, where you will not be finding any cause. Your common causes will not yield you anything, but the child would be having raised CRPs, raised ESR, he would be sick, you would not be able to pinpoint the diagnosis. So that is the time basically to involve a pediatric rheumatologist, PUO, where you're not getting a diagnosis despite adequate workup, despite intensive history, examination, everything, right? So the symptoms would be different. Like I said, the organs which are involved would lead to the symptoms. So what are the symptoms? It would depend upon type and location of the vessel wall, whether the brain, whether the kidneys, whether the eyes, whether the skin. How much is the inflammation? What is the extent of inflammation? And vessel wall damage. The extent of vessel wall damage would also help you pinpoint what degree of damage is there. And of course, vasculitis leads to a lot of hemodynamic changes, especially hypertension. Hypertension, pulse abnormalities, abnormal bruits. So all these things are subtle signs that will point you towards vasculitis. Having said that, vasculitis is pretty rare in children, except for two. One is Kawasaki disease, which I think Dr. Pratap took a beautiful talk last week, and I'm not going to talk about that. The second is the IgA vasculitis, which was previously known as Henoch-Schönlein purpura. This is the most common vasculitis in the world. However, there are some areas of the world like the Southeast Asia, maybe even India, where Kawasaki disease apparently has overtaken HSP in the form of the most common vasculitis. So HSP and IgA vasculitis are used interchangeably. The new term is IgA vasculitis. So epidemiology, the incidence, you can all see. Indian subcontinent, we don't have any registries. These are just some data from the authors, from people who are practicing rheumatology. It's about 24 per 100,000. Other vasculitis incidents we don't really have. So it's very, very important that we establish registries, we start diagnosing, then only we'll come to know what exactly is the epidemiology of childhood vasculitis. So like every other disease, this disease classification has evolved. So the classifications are not very old. The first classification was given in 1990 by ACR. Not going to go in detail, but you should know that it was there, but it is not suitable for children. Then in 1994, another Chapel Hill Consensus Conference that was there, where they included microscopic polyangiitis, but ANCA was not used and was not described. And it was again modified in 2011, and 2012 is the one that we recently used. So what about the pediatric criteria? In 2005, Press and Euler, they basically gave a classification for childhood vasculitis, where they gave different names, which I will just tell you. I will simplify it, don't worry. So they 2005, and then we have the 2008 Ankara classification, which was endorsed by Euler, Pinto, and Press. So what you need to know is that there is a different classification for vasculitis in children and in adults. So what are the three types? Large vessel, medium vessel, and small vessel. I know I am sounding like Goldilocks, but that's the way it is. Large vessel vasculitis, the Papa Bear, so-called, you can say, is Takayasu arthritis, involving the large vessel, okay? Medium vessel. Medium vessel, the Mama Bear, is the childhood pan, cutaneous pan, and Kawasaki disease. And then you have the small vessel vasculitis, which can have two types of inflammation, granulomatous and non-granulomatous. Granulomatous, very easy to remember. It was Wegener's. Why we are not using Church, Strauss, and Wegener's is that these are Nazi scientists and we want to move away from the bad part of the history. So it has been renamed as granulomatous with polyangiitis. And if you have eosinophilia associated with it, then it is eosinophilic granulomatous with polyangiitis, right? So granulomatous. And non-granulomatous is a microscopic pan, a microscopic polyangiitis, Hinoch-Schönlein purpura or IgA vasculitis, isolated cutaneous leucoclastic vasculitis, and hypocomplementic urticarial vasculitis. You can take a snapshot of this because this is the most simplified. What the complicated classification was there, I have really simplified it. Apart from this Goldilocks classification, we have other vasculitis. One is that Behçet's disease. Behçet's disease involves everything: arteries, capillaries, veins, post-capillary veins, everything it is involving. Then you can have secondary to infections, like I told you. Then lupus can have vasculitis, JIA can have vasculitis, mixed connective tissue can have vasculitis. Then there is another entity known as CNS vasculitis, very difficult to diagnose, very, very difficult to treat. It's difficult, right? So, and then you have a whole chunk, which is the unclassified vasculitis, which most of them, when you're not kind of fitting them into a puzzle, you would classify them as unclassified. So what is the pathogenesis? How is this happening? So we all know, all the rheumatologists and immunologists love to talk about immune complex formations. So antigen, antibody, complex formation, and complements are leading to the problem. Then you have ANCA mediated, which is anti-neutrophil cytoplasmic antibody. And then you have the T cell mediated with granuloma formation. Again, in line with the classification of large, medium, and small. So immune complex, what is the classical one? Hinoch-Schönlein purpura and CTD associated vasculitis, right? ANCA mediated, what happens? There is an aberrant expression of these antigens on the neutrophils. They form antibodies. Neutrophils get destroyed. They get recruited. They damage the vessels. This is the simplest pathogenesis slide that I could have made. I hope it's clear. And then these are the two types of ANCAs that we have: P ANCA, which is common in GPA, and C ANCA in the others: microscopic polyangiitis, GPA also, and EGPA also, right? We are moving away from the scientist names. So this is a class, this is how they recruit and they damage the cell wall. Then you have the granuloma formation. है ना? So immune complex formation, we have the ANCA mediated, and then we have the granulomas. Granulomas, like I said, GPA, it's all in the name, and Takayasu. Classical, this granulomas, where do you see the granuloma? You see it when you do a biopsy. You don't see it on imaging. You don't see it on, let's say, angiography or anything. You have to do a biopsy to see it. So everything is clear till now. So now, having known large, small, and medium, and the other vasculitis, knowing the pathogenesis, immune complex, ANCA, and granulomas. Now, how do we approach? So, how will this patient come to you? He will come with three primary problems: fever, where you're not able to find a cause, systemic inflammation going on. The child is having high CRP, high ESR. You do the X-ray, you do the ultrasound, you don't find anything. And that's the time to call in a pediatric rheumatologist. You might see some organ involvement, and I always teach my PGs that, when you're not able to put 2 plus 2 is equal to 4, look for something else. Something else is missing. Your equation is not right. So whenever you get a child with an illness where 2 plus 2 is not equaling 4, that is the time to, think about vasculitis. So learn to recognize vasculitis. I think we as pediatricians, subspecialists, or super specialists, whatever we want to call it, we all are obsessed with recognizing pattern. We have to recognize the pattern, the disease, the nuances of the disease. So pattern recognition, like in Kawasaki, Dr. Pratap sir very nicely said, we are talking about the pattern recognition. HSP, we have the rash, we have the arthritis, we have the characteristic features. So you need to recognize the paradigm, recognize the pattern, recognize the constellation of symptoms that you're going to see. So when should you think of? PUO, systemic features. I went to an MD exam last year, and I asked the PGs, okay, tell me the causes of excessive weight loss in a child. Very intelligent PGs, they told me TB, they told me HIV, they told me malignancies. Very good, not denying that. But please remember, vasculitis is the most common cause of excessive weight loss. The child can lose up to 30% weight loss. If the weight loss is so much there and you're not finding any TB, not finding any malignancy, please think of vasculitis. Talk to your rheumatologic colleagues. Talk to anyone. In fact, put 4 brains together. You will find out the diagnosis. So PUO, weight loss, systemic features, palpable purpura. When you see pulmonary infiltrates, you're not getting CB-NAT positive, you're not getting your cultures, the child is not responding. Think of ANCA vasculitis. It's not necessary that everything is infection in India. Infections are coming down in India. These diseases are coming in the forefront, and we need to know about these diseases. Glomerulonephritis, microscopic hematuria, proteinuria. If a child comes with foot drop, or a child comes with some, let's say, one peripheral neuropathy, or comes with seizures, in one suppose a foot drop or a wrist drop, I would not think of lead poisoning now. Lead poisoning is no longer that common, but I would think of vasculitis because childhood pan, DADA 2, a lot of vasculitis can present with mononeuritis multiplex. Absent pulses. Whenever you're seeing a patient, we always say when we describe pulse, all peripheral pulses palpable. And I'm willing to bet you 25 to 30% of the time, you're not palpating all the vessels. Palpate all the peripheral vessels, inequality of pulses, discrepant BP, hypertension will give you a clue to underlying vasculitis. So myocardial ischemia, Raynaud's phenomena, digital gangrene, mesenteric ischemia, everything should point you towards vasculitis. Look at this. These are the pictures of my children. My children means my clinic patients. This is a child. Like, I think it's no-brainer. What is the diagnosis? You can put in the chat box, what is the diagnosis? This is a child. We classically say extensor surfaces, but look, beautifully you can see these purpuric rashes, right? Look at this. Arm may be here. And look at this. This is so subtle that our dermatologists diagnose this patient as mosquito bites. So be very careful before you say that these are mosquito bites. These subtle rashes will give you an indication. Suppose this child comes to you with pain, abdomen, and vomiting, and these kind of rash, this is not very classical of HSP, but if you're attuned to looking at patterns, you will make a diagnosis of HSP and not miss a deadly disease. It is a deadly disease if you don't treat it properly, if the abdominal symptoms are there. So palpable purpura in the absence of thrombocytopenia. Look at this miliary-like pattern, but no TB workup came positive, no cultures came positive. Think of ANCA vasculitis, microscopic hematuria. Now the step 2 is rule out secondary causes. As pediatricians, you must know rickettsia and mycoplasma cause a lot of vasculitic symptoms. They do, and you must take a good history. You must examine the child. You must investigate for these infections, because these infection-associated vasculitis would only be treated by antibiotics. Rarely would they need any steroids or any immunomodulator. So, infective endocarditis, rickettsia, hepatitis B, C, HIV, drugs like phenytoin, sulfur drugs, allopurinol, thiazides, or TTP and HUS, like the patient may come to you with TTP, HUS. So rule out secondary vasculitis, like vasculitis, I would not say secondary vasculitis, but vasculitic-like lesions may be present in Apla syndrome, lupus, JIA, leukemias, lymphomas. See, the list of differential is huge. So the investigation that you have to do is to rule out other differentials. If you've recognized pattern, go ahead, treat the vasculitis. But sometimes, most of the times, HSP, KD, yes, easy to diagnose. The others, very, very difficult. Very, very difficult. Just a minute. Yeah. So, step 3, what is the pattern of involvement? We talked about Goldilocks, right? Papa, Mama, and the baby bear. So, large vessel, medium vessel, and small vessel. So, large vessel, what will you see in large vessel? Because your aorta will be involved, your subclavian, your brachiocephalic trunk. So, you will get limb claudication. The child will walk for some time, sit down, he gets tired. Asymmetric BP, absent pulses, bruit, and aortic dilatation. Medium vessel mein what you will get? You will get digital gangrene. You will get mononeuritis multiplex. You will get cutaneous nodules, ulcerations, livedo reticularis. Small vessel, again, what will you see? You will see purpura, like in HSP. You will see bullous nodules. You can see urticaria. You can see splinter hemorrhages. So small vessel is recognized by predominantly cutaneous findings. Or they can have glomerulonephritis. They can have diffuse alveolar hemorrhages, which is commonly seen in ANCA vasculitis, and it can be fatal if you don't recognize and you treat with immunosuppression. So again, just take a snapshot of this. Large, medium, and variable vessel is Behçet's and Kogan. Small vessel is our ANCAs. So learn the characteristic presentation of common vasculitis. So HSP, we all know, pain, reddish raised nodules, right? Kidney problems and all these issues, right? So pattern recognition. Kawasaki, I will not say because Dr. Pratap has already. So how do we now diagnose? We have recognized pattern, we have examined the child. Now what? Next step, look at the blood investigation. Mild anemia, eosinophil predominance, neutrophil predominance, platelet counts, ESR, CRP, they will give you a hint. Viral markers, hepatitis B is often associated with PAN. Hepatitis C associated with essential mix, cryoglobulinemia. Usually hypergammaglobulinemia will be there. Elevated IgA can be helped to, you can make use of this investigation to do hinox-Ronin purpura diagnosis. Rheumatoid factors like in JIA or known case of lupus, they might be of helpful. ANCAs. ANCAs are again very important. You should do P-ANCA and C-ANCA both, but most of the time, these children are sick. Suppose they present with diffuse alveolar hemorrhage with ARDS like picture with respiratory failure. Suppose they present with glomerulonephritis and renal failure. So what do? Do you wait for ANCAs? No, you recognize pattern and you pulse these children. You give high dose corticosteroids because otherwise you will lose these children. You need to be very, very aggressive in your diagnosis. You need to rule out infections fast. If you cannot rule out infections, give broad spectrum antibiotics, give IV immunoglobulins. That will give you around 48 hours to rule out your infections. After that, pulse these children ASAP. Otherwise, organ damage will be irreversible. Do an ANA, like we said, it has been told multiple times, do it by indirect immunofluorescence. Do a urine investigation. One of my senior professors used to say, urine examination is a non-invasive biopsy of the kidney. And it's very, very right. If we do it properly, urine routine examination can give us a lot of findings. Now, tissue biopsies. So where do we get the tissue? Whatever tissue is involved. Suppose the lung is involved, do a lung biopsy. Kidney is involved, do a kidney biopsy. And please remember that sending the biopsy only for pathology is not good. You need to do the direct immunofluorescence in the tissues. That's the most important part. That is the clincher. Suppose you do a biopsy in HSP patient and you don't send the immunofluorescence. The only thing that the pathologist is going to tell you is that this patient has leucoclastic vasculitis. Leucoclastic vasculitis means nothing to me. It does not mean anything. So what the value is added when you see what is deposited in the biopsy. Suppose it is IgA or IgM and C3. I know it is HSP. Suppose it is IgG and complement. I know it is lupus associated. So you need to do a pathological histopath and you need to do direct immunofluorescence. Very, very important take-home message. Renal biopsy, again the same thing. Immunofluorescence and do your histopath. Skin biopsy. See, skin biopsy, like I said, leucoclastis can be seen in any vasculitis. But you need to see what is being deposited there. Do a chest X-ray. Do an HRCT thorax. You will find pulmonary infiltrates in small vessel vasculitis, especially cavities. If cavities are there, think of GPA, think of eGPA. They present like asthma with eosinophilia. Do sinus X-rays. You can see sinusitis in GPA. So adolescent who are presenting with sinusitis, which doesn't seem infectious to you, think of vasculitis. Why not? Do a biopsy. CT angio is the most easily available, very easily done investigation, and it gives you a wealth of information. But what is the disadvantage of CT angio? It is not very good for small vessel vasculitis. Small vessel vasculitis predominantly relies on biopsies, while medium vessel vasculitis and large vessel vasculitis, you will be able to make a diagnosis on angiography. MR angiogram, slightly better than CT angio. If you're not able to do an MR angiogram, don't fret, don't get upset, do a CT angio. The only advantage of MR angio over CT angio is you can visualize the vessel wall. You can actually see the vessel wall inflammation. Like in Takayasu's, we have around 12-13 patients of Takayasu under our follow-up. We prefer doing an MR angio because we need to see the vessel wall. And the disadvantage is that, sometimes when the spasm is there, the MR captures it as occlusion. So you have to really discuss with your radiologist. Digital subtraction angiography, I have not used it in my 9 years of my career. It's not that commonly used. Nowadays, the guidelines of vasculitis have changed. We are moving away from stenting renal arteries, stenting of different arteries to remove occlusion. The guidelines are saying do more immunosuppression because these stents can tend to get occluded. So DSA is not very commonly used. I have not used it. But this is for the sake of you can do an ultrasound Doppler. Color Doppler imagings are very, very easy. Doppler can have a role for screening because it will be available in all the hospitals. PET CT is another investigation. I would like to tell my pediatrician colleagues, whenever you get a PUO case, please do not put ATT in these children without, isolating, like Ajay sir was also telling in the morning that now the guidelines are saying you must isolate bacteria. If you're not able to isolate mycobacteria, if you're not getting a typical picture of tuberculosis, go a step forward, call your rheumat colleagues, call anyone. Put 4 or 5 brains together, you will find a diagnosis. And most of my Takayasus, okay, Takayasu is different because tuberculosis has this thing. Most of my PANs, most of my lupus always have received ATT. And it's a sad part nowadays when we have such huge diagnostic techniques that we are still resorting to ATT, putting ATT empirically. So PET-CT is another gold mine that can differentiate between TB, vasculitis, malignancy. So, but it's a little expensive. So what are the principles of treatment? See, principles of treatment is you need to save the child's life. I'm not saying that, pulse a child with cutaneous vasculitis. No. Cutaneous vasculitis without any systemic findings, you can wait. Do a biopsy, take your time, get the report. Most of the time, they're self-limiting. You don't need to do anything. But you need to remember, like in lupus, where we have end organ damage, like if you have CNS vasculitis, you have glomerulonephritis, you have failure, renal failure, you have ARDS-like picture, you have diffuse alveolar hemorrhage, the child is sick, child is having gut ischemia. Gut ischemia can be so bad. If you miss a diagnosis of HSP and you do not treat, it can lead to gangrene, it can lead to surgical outcomes are also not very good. So you need to be aware. You need to see how sick is the child, what is the organ that is involved. And most of the time, when you're confused between infections and vasculitis, what you can do is put broad spectrum antibiotics, give immunoglobulins to tide over the immunomodulation. In 2 days' time, you will have your procalcitonin, you will have your provisional cultures, you will come to know in 48 hours a child would improve with antibiotics. If it is not improving with antibiotics, why are we continuing to think that this patient is infection? You must immunomodulate ASAP. There is a saying in rheumatology, enable a patient, don't label a patient. A lot of times, do not wait for labels. ANCAs can take up to a week. It takes time to get investigations. But if you recognize pattern, you have organ involvement, pulse these children. If you have CNS, renal, ocular, we had a child with retinal vasculitis. I think my senior Dr. Mahato sir was treating that patient. I still say Mahato sir saved that child's eye. The quality of life was improved. He just gave cyclo and we treated that child beautifully, and that child is now would have lost his vision. So you really need to pulse these children. Use cyclophosphamide. Do not be scared. You need to save the child first. Labeling can be done later on. But sometimes in vasculitis, if you do not have that degree of severity, you can go ahead with your investigations, but do not wait for a week, 10 days for MR angio to come. No, 48 to 72 hours, you should have your ducks in a row and you should have your plan in place. So choice of therapy, again, like I said, degree of organ damage, multi-system involvement, which is the vascular bed that is involved. You should use glucocorticoid and cyclophosphamide. It's the preferred. So cyclophosphamide, what we usually do is we start with 500 mg per meter square. If the child tolerates, we go up to 750 mg per meter square, 6 pulses weekly. Glucocorticoids, 30 mg per kg per day of 3 to 5 pulses. Glucocorticoids, like in mild disease, may suffice. In mild vasculitis, aspirin and IVIG in Kawasaki. So whenever possible, rule out secondary causes. Mycoplasma must be ruled out. Rickettsia must be ruled out because they are the causes of secondary vasculitis. You would need to treat the infection, and immunomodulation alone would not help. And you need to really think about long-term steroids because our children are growing, the toxicity of cyclophosphamide. But I believe that first of all, you need to save the child's life, save the major organs, because see, saving a life of a blind child. You've really, I don't know, his quality of life is really gone for a 6, right? If the child has lost its vision, we have not done our job properly. So regular monitoring of counts, hepatic renal function. So HSP is the most common one. I would like to just skip through this because I've spoken about it. I would like to discuss a case with you people. If it's, I think this is a very, very difficult case. I'm sure a lot of people would have a lot of comments. Please post them in the chat box. So this was a 16-year-old female, a resident of New Delhi. She was diagnosed with tubercular lymphadenopathy around 1 year back before she came to me. She took ATT for 9 months. Her FNAC was suggestive of epithelioid granuloma with caseous necrosis. Fair enough, tubercular lymphadenopathy. I'm not denying that. TrueNat, MTB was detective and RIF resistance was intermediate. The child was just given ATT and RIF resistance, whatever was there. Nothing was done for that. So that was a gap in the care of the child. So when this patient came to me after a year, she had malaise, she had persistent loss of appetite, and no weight gain since 1 year. In fact, on ATT, she lost 15 kgs. This child was a 45 kg child, and when she came to me, she was 29 kilos. And then she had persistent left axillary swelling and low-grade fever for a month. So looks like a resistant TB? Yes, let's see. Another problem that she had was umbilical pain, which was dull in nature, non-radiating, no other problems. Chest pain, which was like with dull aching kind of a pain, and pain in the left arm whenever she was working. So some kind of claudication. So can somebody put in the chat box what kind, if I'm suspecting vasculitis, what type of vasculitis? There was no other symptoms, no stroke, no eye, no nothing. Going on to examination. See, left arm did not have any pulses. So large vessel vasculitis, I think somebody has typed. Good. So pulse rate was a little high, not palpable in the left arm. BP was 90/70. So there was a discrepancy even in the pulses, right? So I think, so there was pallor, there was solitary left axillary lymph node, which was present. And what was very important was my resident beautifully picked up a bruit in the epigastric area. Rest of the examination was absolutely normal. So look at the investigations. We have anemia, we have little relative thrombocytosis, very high CRP, very high ESR, 70 and 152. So systemic inflammation is going on. Microcytic hypochromic anemia, fundus was normal, VDRL was normal, HIV was negative, hepatitis B was negative, and iron profile was suggestive of iron deficiency anemia. X-ray ECG was normal. So what we did the axillary lymph node histopathology. So in histopathology, there was necrosis with palisading histiocytes with multiple foci or in the lymph nodes. So when we discussed with our pathologist, they said that this is not characteristic of TB. This can be lupus, this can be sarcoid, this can be anything, but we were not really sure. ZN staining was negative, but CBNAT again detected an MTB. But please remember that RIF resistance was not detected, which means that it is not, it's probably some dead bacilli. I don't know what it was, because the MJIT that was awaited has come recently and it came out to be negative. So it was not probably TB. So ultrasound Doppler showed long segment echogenic concentric wall thickening in carotid, subclavian, axillary, and abdominal aorta along with renal arteries. So all your large segment arteries, large arteries are thickened, and no color flow in the left brachial, radial, and ulnar artery. So what did the chest CT show? It showed what we have seen in the Doppler. Concentric mural thickening of ascending arch, descending aorta till the renal artery, brachiocephalic trunk, common carotid, and subclavian artery. Right? And there was no evidence of TB, no pulmonary infection. Echo was normal, MRI spine was normal, and DEXA showed osteoporosis. So what is the diagnosis? Is it TB? Is it tubercular aortoarthritis? Is it Takayasu? And in real time, I didn't know what to tell the parent. So for this case, I would like to thank my husband and my teacher, Dr. Sameer Gulati, whom I consulted. He's an adult rheumatologist. And he said that this looks like Takayasu and does not look like tubercular aortoarthritis, because in tubercular aortoarthritis, you only have the aorta of the chest involved. But since this patient also had aorta, abdominal aorta involved, so it's likely to be Takayasu. So now the problem is that the patient, I have TB, I have Takayasu. TB needs ATT, Takayasu needs immunosuppression. And this kind of a disease, type 5 Takayasu, involving all the vessels, very, very difficult for us to take a decision. So what did we do? In consultation with our adult colleagues, we discussed and we gave ATT. And then what did we do? We just gave her steroids. We pulsed her. We gave her IVIG, followed by pulse. And then we started her on MMF. She now continues to do well. And this child it's still difficult because her disease is not getting controlled. So what we are thinking is that we give her tocilizumab or put her on tofacitinib, so that we are in contact with the adult team. So what we'll be doing, I'll update in the next talk. So the challenges are there in these patients. How to diagnose infection versus this thing. Just give me one more minute. I want to I'll go through one more case quickly. This is a are my slides visible?
Yes, ma'am.
Yeah.
Full screen.
So a 17-year-old teenage boy, again an older kid, clinical features: weakness in the left little finger with sensory loss in the medial aspect of the palm. This happened at 10 years of age. No history of trauma, fever, weight loss, or any swelling. What did the investigation show? They showed sensory motor axonal neuropathy of the left ulnar nerve, right? So one nerve involved, right? An MRI of the left elbow showed mild erosive changes in the elbow joint. So systemic inflammation. Systemic inflammation with one nerve, you should start thinking of vasculitis. But sadly, this is not what happened in this child. This child came to me at 17-year-old and the symptoms began at 10-year-old. So 7 years gap of diagnosis. So phenotype was mononeuropathy. He was put on anti-tubercular drugs. He was given oral steroids and he recovered in a month's time. So here I would like to say he probably responded to the steroids and ATT was not warranted because there was no evidence. Now, what happened at 15 years? So 5 years he was fine. He at 15 years of age, he had acute onset diplopia, gait ataxia, vertigo, vomiting, paresthesia. No history of head and neck trauma, no facial symmetry. Now, MRI brain was done. It showed ischemic stroke in the left lateral aspect of midbrain and pons. This is not a common area where a stroke occurs, right? So if you can type in the chat box, what type of vasculitis are we talking about? So here it was, diffusion weighted sequence. I've put an arrow here where you can see the midbrain stroke. Midbrain stroke are very, very rare, very, very rare. I have not this was because if I didn't see the MR films, I probably wouldn't have believed the written MR report. But yes, it's definitely there. So, this is just for the PGs. Vestibular area causing ataxia, vertigo, vomiting. Spinothalamic tract was probably responsible for hemisensory loss, and PPRF involvement was probably horizontal gaze palsy, and cerebral peduncle was leading to ataxia. So it was like that. Then what happened? The MRI I have shown, stroke, prothrombotic workup, everything was negative. P-ANCA, C-ANCA was negative, but however, the ANA was positive. So that's again a little weird. Why we didn't, okay, ANA is positive. So what did we diagnose? Posterior circulation stroke. Aspirin, rehabilitation and recovery was in 3 weeks. So next, what happened? At 16 years, So what did they do? They gave aspirin and he was fine. So they didn't do anything. Here also no diagnosis. Now at 16 years, 1 year later, he had right foot drop, sensory loss over left lateral leg, no history of trauma, no history of injection, no fever. So NCS showed sensory motor axonal neuropathy now in the right peroneal nerve. See, previously it was in the ulnar nerve. Now he is having another nerve. So recurrent moroneuropathy, short course of steroids was given and he responded. Then what is? After 16 years, 10 months, that is after 10 months, he had hearing loss. It's so sad that he's, shouting that I'm having a vasculitis, please treat me, because of what would I say, lack of awareness. This patient lost 7 years between diagnosis and, the onset of symptoms. So there was acute onset bilateral sensory neural hearing loss. PTA confirmed the same. MRI was normal. DSA was normal. Vasculitic workup was negative. Metabolic workup was negative. PET was negative. So phenotype was recurrent mononeuropathy with cranial neuropathy, systemic vasculitis. They gave us short course of steroids and he responded, right? So, and at 17 years, when he came to us, we took the history again. He was a male born to a non-consanguineous marriage. They were of the Agarwal community. Can you please put the diagnosis in the chat box? Agarwal and Jain community have this diagnosis very commonly there. So there was nothing. He was a very well-built child, extremely tall, but he had hearing loss. So investigations showed ANA positivity. Rest of the workup was negative. And MTHFR mutation, which is a procoagulant, was heterozygous, but it was not significant. We discussed with the geneticist. So this child has recurrent acute multi-site neurological symptoms with recurrent mononeuropathy, SNLH, and ischemic stroke. So what did we do? We put the diagnosis as neurometabolic disorder, systemic vasculitis, and inherited vasculitis. So we did for and against. You can take a snapshot of this, but this was looking like systemic vasculitis. Then what did we do? Because this child had only partial response to steroids, did not basically had symptoms onset at 10 years of age, a young child. So we went ahead and did the whole exome sequencing, which turned out to have ADA2 deficiency. So this is a DADA2, which is DADA2 is deficiency of ADA2 deficiency defect, which I had mentioned in my monogenic one. And this was a likely pathogenic mutation. So this patient was diagnosed as DADA2, which is associated with vasculitis, autoinflammation, immunodeficiency, and hematological syndrome. So our patient only had vasculitis. So DADA2 was the diagnosis. Segregation, both parents were heterozygous and sister was found out to be the carrier of the variant. So what were the treatment options? We put this, that only treatment option is TNF-alpha inhibitors, and that's what we did. The child, after 5 years of follow-up, is now in college, finished his college, and only has mild hearing loss as of now. He's absolutely fine. I'll stop to share my slides here. I think I thoda lamba ho gaya, but I apologize.
Thank you, Dr. Anu, for a wonderful presentation. We welcome our President, Dr. Pankaj Garg, sir, Vice President South Zone, Dr. Preeti Galgali, ma'am, and Dr. Nandish, sir. And on behalf of IP Delhi, I congratulate Dr. Preeti Galgali, madam, for being elected as the Vice President of the International Association of Adolescent Health. Congratulations, ma'am.
Thank you so much, Dr. Ajay. But listening to Anu today, I was just thinking, how many patients have I missed? And actually, Anu, you're making me feel terribly guilty.
No,
And
actually,
thank you
these
so
are
much.
awareness sessions because
yes,
what we don't know, what that we don't see.
Exactly. And very, very enriching and excellent session. Congratulations to all of you.
Thank you, ma'am. Thank you. Thank you so much. I hope I was able to do justice. It was very difficult topic.
I request our chairperson, Dr. Chaudhary sir, to please say a few words before anything.
Excellent presentation, madam. You have justified the topic, difficult topic, simplified as much as possible. So I have one question, that what biopsy will you take for sinusitis patient?
Yeah, sir, most of the time we do a posterior rhinoscopy and we can do laryngoscopy and endoscopically the ENT people can do when they do the fenestration, they can take a biopsy. And it's quite difficult, sir. Most of the time the nasal mucosa will show some changes. So you have to involve your ENT colleagues and they would take a biopsy from a pathological area and you will see granulomas in that. Most of the times sir nasal biopsy se ho jata hai.
Okay, thank you, ma'am.
Ji sir.
I request our President, Dr. Pankaj Garg, sir, to say a few words. Dr. Pankaj Garg, sir.
Yeah. Hello. I'm sorry.
आप वीडियो ऑफ कर दीजिए सर, वीडियो वॉइस क्लियर नहीं आ रही.
Whatever I could listen to Dr. Anu is always just get out of this. So this was a very interesting talk, whatever I could listen at the end, but I'm sure I will listen to it in the recorded session. And I definitely thank Dr. Ghanshyam Chaudhary and Dr. PT, Dr. Nandish, who was Dr. Bennett. They are all in the panel. They are so interested in IEP activities. They're attending many of these sessions. So it's very nice. And thank you again. Definitely, this is the second last session. Next will be the last of pediatric rheumatology, and then we start pediatric cardiology sessions. So it's very nice that Anu has been the master of all these activities which we are doing in pediatric rheumatology field, and of course, Dr. Ajay. So thank you so much.
Thank you, sir.
Thank you.
I request Dr. Nandish, sir, to say a few words.
Sir, very good morning to all the esteemed dignitaries. I congratulate IAP Delhi, Dr. Ajay Kumar Gupta. I congratulate Dr. Anu Madam for taking wonderful session, which made a complex topic as most presented in the simplest way. Very, very nice, excellent presentation, Madam. Let this process of teaching continue. Let IAP Delhi flourish in giving academics to all members. Thank you, sir.
Thank you, sir. So I'm thankful to all the delegates who joined in and Dr. Dolly Madan also, who helps with all the question and answers, and IP Delhi staff who manages the whole channel. And I'm again thanking all the faculties and the chairpersons and all the delegates. So please join us again next Sunday for the last of the series of this pediatric rheumatology sessions. Thank you very much.
Thank you, sir.
Thank you, sir.
Dr. Shyam, sir, you want to say something? We are organizing one pediatric conference of North India on 30 and 31st of August at Hotel Lee Meridian. Please register for that. It will be associated with North Zone Pedicon and also North India Pediatric Infectious Disease Conference on 21st and 22nd of June at Hotel Lee Meridian again. So please register for that also. Thank you so much.
Thank you very much. One small doubt for me from my
Yes.
side.
Yeah, sure.
Excellent presentation. Actually, it's an enjoyment to hear about your experience and the talk. My doubt is regarding the urticaria. Suppose a child is getting recurrent urticaria or chronic urticaria. Are you suggesting to do a biopsy for all these children?
No, no, sir.
And you are not getting the proper like permanent cure. And whenever we give medicines, the child will get some improvement. Again, it will recur.
Yes.
Will you suggest biopsy?
No, no. Sir, all urticarias do not warrant biopsies. What I said was ki if a child is, let's say, getting urticaria, you put a circle with a pen around the lesion. You wait for 24 hours. If that urticaria is persisting for 24 hours, then only you have to think of urticarial vasculitis. Otherwise, this is allergic and this is common childhood urticaria. Urticarial vasculitis lesions will persist beyond 24 hours. And so whenever you will do a biopsy, do from the lesion which has appeared within 24 hours. Don't do it from the old lesion. So to diagnose urticarial vasculitis, the urticaria has to persist beyond 24 hours. If it is going away in 6 hours, then it is not vasculitis.
Ma'am, the waiting for 24 hours is with the medicine or without medicine?
Mostly, if it is urticarial vasculitis, it will not go away with your anti-allergic. So you can give the medicine to the child, put a circle on that lesion, ask them to come back after 24 hours. If it's persisting, label as urticarial vasculitis and do the biopsy from the freshest lesion, the newest.
Any lesion which is lasting more than 24 hours, you are supposed to do a biopsy.
Yeah, yes, yes.
Thank
That's
you.
the Hanji sir. Ji sir. Ji sir.
Thank you.
Thank you, sir.
Thank you, sir.
So, Dr. Meena, sir, please.
Sir, I just want to give the one small message. Dr. Anu rightly said that this one is a multi-systemic disease that can be involve the any of the organs. But I said as a gastroenterologist, many cases we seen in the emergency as a massive or sometime a recurrent GI bleed. So in that situation, because if the ongoing vascular inflammation going on that subsequently cause the pseudoaneurysm or aneurysm like feature that may be ruptured and cause as a massive GI bleed. So sometimes like the DSA, she said that DSA is not too much role, but in our aspect as a GI aspect, DSA is, might be sometime maybe therapeutic role along with diagnostic, because by the DSA we can put the some glue or obstruction of that vessel that is a life threatening. So whenever child come with the GI bleed and especially
Yes,
just like the
absolutely.
messy or recurrent GI bleed might be considered the vasculitis. And one of the important thing, madam, I heard from your side is weight loss, because many cases that have the fever and weight loss, just our thought is totally concentrated toward the
Yes.
tuberculosis or malignancy.
You must
But
think of vasculitis. You must
definitely,
be
today's
thinking
I
of vasculitis.
that is very important.
Yeah.
Thank
Thank you.
you. Thank you.
Thank you. Thank you. Thank you, ma'am. Mr.
Thank you,
Sushil.
sir. Thank you so much. Thank you, sir.
Thank you. Thank you, everybody.